So this is the final session. I'm delighted to welcome Rachel Nicoll, and she's talking on mitochondria function.
Right. What am I talking about? It's actually cardiovascular disease. So cardiovascular disease mortality has been quite a success story in recent decades, declining massively, but not any longer. So the rate of decline has slowed. And here was a very interesting 2019 study, which found that in 12 out of 23 nations, cardiovascular disease mortality is now rising. And 3 of those nations were the UK, Germany, and the US. So this does not bode well. So let's look at mitochondria in heart function. So I said at the beginning that the heart depends on mitochondria for 95% of its ATP, and the remainder comes from glycolysis. So the heart has one of the highest energy demands in the human body. So it needs energy to keep the heart pumping, and it also needs huge supplies of oxygen for oxphos. So this makes the cardiovascular system also uniquely vulnerable, not in the same way as neurons were, but in their own way. And most people with cardiovascular disease are going to have some form of energy deficiency. There are other disadvantages in cardiac myocytes as well. Firstly, they can't travel. So do you remember when neurons, I talked about how the mitochondria congregated around the nucleus and then traveled down the axon to the synapse, so at the neurotransmission. So they can't do that in a cardiac myocyte, and they also don't undergo fission or fusion. So quality control is going to be severely impaired. However, cardiac myocytes can overcome these limitations to some extent. And they do this by forming large static interconnected networks of mitochondria in each cell. And they do this in order to coordinate their ATP production and exchange parts, which is normally subunits of the electron transport chain complexes. And this repairs the damaged mitochondria and makes the whole production of energy more efficient. So they can achieve this by 2 means. Firstly, adjacent mitochondria kissing, as it's called. And the second way is by building a nanotunnel between non-adjacent mitochondria. So I tried to find you some pictures of this, and I found, here's the nanotunnel. Isn't that clever? 2 non-adjacent mitochondria forming a nanotunnel to exchange parts to improve energy production. Amazing. So then I tried to find also a picture of mitochondria kissing, but I failed miserably, so I had to show you this instead. So let's have a look at mitochondria in cardiovascular disease development and progression. So most cardiovascular problems have their root in failure of mitochondrial energy production. So we're talking about angina, hypertension, atherosclerosis, ischemia, heart failure, diastolic dysfunction, all to do with failure of mitochondrial energy production. So when we started out, I said that glucose was nearly always the preferred fuel. Here's the exception. In the heart, the preferred fuel is fatty acids for beta oxidation. So actually, when you get into heart disease, and particularly in heart failure, because you haven't got enough energy for the body to, for the heart to pump properly, and you haven't got enough oxygen to run oxphos, then actually what happens is the heart has to go into anaerobic glycolysis. So inevitably then you've got lactic acid buildup, so risk of angina. incomplete beta oxidation in the heart has been associated with heart failure, ischemic heart disease, and also diabetic cardiomyopathy. Heart failure is associated with a gradual decline in the bioenergetic reserve capacity of the myocardium and with decreased mitochondrial biogenesis. None of this is going to help. So I said when we talked about what can damage the mitochondria that I was going to deal with statins. Now, this is my moment. Here we go. So statins work by blocking HMG-CoA reductase, and that means that production of CoQ10 is also blocked. This leads to lower ATP production because, of course, CoQ10 is the electron acceptor in complex 1 and complex 2, increased electron leakage from the electron transport chain, and consequently increased free radical production. And here's a study of rat mitochondria, that as well as the increased free radical production, they also found mitochondrial swelling, so that stops the mitochondrial working so well, collapse of the mitochondrial membrane potential, so that means that the protons can't flow back from the intermembrane space into the mitochondrial matrix, cytochrome C release, so the cell is going to commit suicide, DNA fragmentation, this is never good, and up to 96% decreased beta oxidation and ATP levels. Statins. Hardly surprising then that some scientists have referred to them as mitochondrial toxins. And of course, that's not to mention the incidence of statin-induced myopathy. And depending upon which study you look at, the incidence is either 5% or 29% or somewhere in between. But this wouldn't be so bad, would it, if statins actually prevented cardiovascular disease? Oh, you know what's coming, don't you? Here's a 2015 systematic review of statin trials, found that in primary prevention, that's preventing your first heart attack, the mean postponement of death was just 3.2 days. And in secondary prevention trials, that's preventing your second heart attack, death was postponed by 4.1 days. Was it honestly worth it? Also, amongst those with life-limiting illness, those who discontinued their statins, oh, shock horror, had improved quality of life and fewer cardiovascular events. And here's a 2015 study which showed that statins can actually cause atherosclerosis and heart failure through depletion of CoQ10. Oops. So this was so worrying that in 2019, a group of UK doctors and scientists, led by the cardiologist Dr. Aseem Malhotra, who are probably familiar to many of you, also included, by the way, the editor of the BMJ and past president of the Royal College of Physicians, wrote to the British Parliamentary Society, Parliamentary Science and Technology Committee to express concern. The chair happily agreed with their concerns and has called for a full investigation. Now, I suspect this has probably been overtaken by COVID and will be quietly shelved. But yes, a lot of people nodding. But we'll see. I don't think that Aseem Malhotra is going to give up that easily somehow. Statins also double the rates of diabetes, and diabetes is a key risk factor for cardiovascular disease. Can you see the ridiculous circularity of that? So we've known about this for a long time, but nobody's taking any notice. But here's a 2019 study. It's found that statin users had a 220% risk of higher risk of developing new onset diabetes, and those taking statins for more than 2 years had a 333% higher risk. Great. So now Sarah has already introduced this wonderful cardiologist for me, so I barely need to. No, I'm delighted. Metabolic Cardiology is a great book. It's quite old now, but there's nothing in it that's old. It's all highly relevant. And Stephen Sinatra made a massive contribution to the understanding of the importance of the mitochondria in the heart. And he points out that the adenine nucleotides, so if you remember that's ATP, ADP, and AMP, they decline more than 30% in heart failure and more than 40% in coronary artery disease and ischemic heart disease. Now, he's focused principally on heart failure, And before we go into his treatment, I'd like to point out that conventional medicine has no cure for heart failure. It only has symptomatic relief. So he regularly prescribes what he calls the awesome foursome, which is CoQ10, L-carnitine, magnesium, and D-ribose for virtually any form of cardiovascular disease to great effect. So let's see what he has to say about CoQ10. So he published 4 papers showing a correlation between levels of CoQ10 and severity of heart failure and the value of supplementing CoQ10. After the latest paper, which was in 2004, he gave up because he realized that conventional medicine was taking no notice and nothing was going to change medical opinion. Furthermore, I just saw a recent statistic that less than 1% of good medical research makes it into clinical practice. So actually, what's the point? And I totally sympathize with his perspective. I used to write a lot of review articles. I virtually stopped because nobody's taking any notice, nothing's changing. Change will come from the grassroots, which is where you all come in. So good on you. So many studies have shown deficiencies of CoQ10 in all forms of cardiovascular disease. And of course, as we said before, its production is inhibited in anyone on statins. So he recommends CoQ10 should be the first defense against heart failure or dilated cardiomyopathy. And he recommends using ubiquinol rather than ubiquinone. He thinks you should be guided by blood levels when it comes to dosage. So I've given his suggested levels there and a few other points. L-carnitine. So we saw before that fatty acids are the heart's preferred energy source. But if you remember back to lecture 1, they need an adequate supply of L-carnitine for the carnitine shuttle to take those fatty acids into the mitochondrial matrix. And carnitine not only promotes OXPHOS by transporting the fats for beta oxidation, but it also helps to clear lactic acid. So that's really useful. And I've got lots of carnitine studies in my Annex F, but I'm just going to talk about one of them because I think it encapsulates the effect very nicely. So patients with heart failure and dilated cardiomyopathy given 2 grams per day of carnitine versus a placebo. After a mean 34 months, 18.1% of the placebo group had died compared to 2.7% of the L-carnitine group. And I think that says it all quite nicely, really. Carnitine supplementation then, yes, commonly seen in heart disease. He uses it to help patients with angina, heart failure, peripheral vascular disease, and arrhythmia. And it also lowers total and LDL cholesterol and triglycerides and raises HDL. So what's not to like, basically? Magnesium, yes. So I've already said magnesium needs to attach to the ATP to activate it. And it also is a natural calcium channel blocker, which is really useful. And he recommends 400 milligrams a day as preventive, higher doses if you're at risk or there's pre-existing cardiovascular disease. D-ribose is the 4th one. And this is where it gets a bit complicated. And I'm sorry, because it's late in the day, 3:45, but bear with me, we will get through it. So in a healthy heart, the ATP, ADP, and AMP ratios are maintained fairly constantly. And if you remember how ATP is exchanged for ADP across the mitochondrial membranes, you can see why that would need to be so. All good. In a diseased heart or an oxygen-starved heart, though, as you can imagine, this is not happening. So the cell has to revert to anaerobic glycolysis with the glucose and pyruvate being metabolized to make the ATP and the lactic acid. And when the AMP, ATP, and ADP are not metabolized, they leak out of the cell. And so the means of producing more ATP is gone. You can get it back, but it's a long and slow process. So he points out that 2 hours of transient hypoxia can deplete nucleotide reserves by 15%. But in heart failure, ischemic heart disease, and cardiomyopathy, the depletion can be as much as 50%. And if you're never going to get that back, there's not a lot of hope for you, frankly. But you can rebuild the adenine nucleotides. So AMP comprises adenine, ribose, and a phosphate group. And then to make ADP, you just add another phosphate group, ATP, yet another one. That's all quite straightforward. And there's not normally a shortage of those phosphate groups. What there is a shortage of is adenine, which is a purine derivative, and ribose. Rebuilding a stock of purines can be slow, and it needs ribose anyway, but the availability of D-ribose is the rate limiting factor in rebuilding AMP. So there are two possible pathways that the body can use. There is the slow pathway, which is purine salvage, and this can take nearly 10 days to rebuild the purine pool. Or there is the very slow pathway. This is de novo purine synthesis, so you're creating a D-ribose from glucose from scratch via the pentose phosphate pathway. This can take up to 100 days. But there is an alternative, and that's supplementing D-ribose. This can rebuild the purine pool within 2 days. So, and again, no drugs have yet been found that can rebuild the cardiac purine pool. Sinatra recommends D-ribose for any form of angina, heart failure, and dilated cardiomyopathy, and in any patients on inotropic drugs, which makes sense. And he recommends 15 grams in 3 divided doses. Now, 15 grams is an awful lot of D-ribose, and you can get it in powder form, in capsules, and in tablets. But if you're asking your patients to take tablets or capsules, it's a lot, particularly for people who hate taking pills. I took Jarrow's tablets, which are that size, so you can see the problem. Fortunately, they're absolutely delicious because they taste of raspberries. But this is going to be a very careful negotiation with your patient. But if they haven't noticed any difference in, say, 2 weeks, then they can stop. Probably they'll notice the difference once they stop. They'll think, oh, I don't have as much energy as I used to. Anyway, that is Stephen Sinatra's recommendations. And he has a few more as well, which are these, all of which won't be new to you. So let's look at our mitochondrial therapies then. So caloric restriction and fasting, yes, very good. One of my review articles before I stopped writing them was actually on fasting and hypertension. So I can report that it is highly successful in lowering it. Ketogenic diet, yes, great. So much so that a Lancet study called for revision of the dietary guidelines. Needless to say, that didn't happen. Exercise, yes, all good. And near infrared radiation, which seems to be very good in animals, at least. Not quite sure if this translates to humans, but in animals, it showed an up to 76% reduction in infarct size. And that's definitely worth having. So here are the mitochondrial remedies. And you can see the awesome foursome in there, not too many others, unfortunately, but you can see the details of all of these at Annex F on my website. So that concludes cardiovascular disease, and now I'm going to talk about autism spectrum disorders. So you don't need me to tell you that there is dramatically increased prevalence in recent years. It's been described as an autism tsunami, which is a gift for anagram spotters. So according to the Centers for Disease Control in the US, it's the fastest growing developmental disability, affecting 1 in 59 children. In the 1970s, this was 1 in 5,000. Now, admittedly, diagnosis has improved, but not that much. So conventional medicine has taken the genomic approach again, as with cancer. The US has thrown more than $1 billion at this. And guess what? They found that hundreds of genes can play a role, but no single gene accounts for more than 1 to 2% of autism. Our DNA just cannot change this fast. So what they have talked about there is autism susceptibility genes. And I put those in inverted commas for a reason. Because if you've ever heard me speak on environmental toxins in autism, you might remember that I picked up on 2 of these so-called autism susceptibility genes to see what they really did in the body, because their function is not to produce autism. In one of them, it facilitates detoxification. So a mutation reduces detoxification ability. And in another one, it facilitates transport of toxins across the blood-brain barrier. So these are not really autism susceptibility genes. And I think that is a really bad name. Firstly, because it implies that autism is genetic. And secondly, because it masks what's really going on. Too many environmental toxins and insufficient detoxification ability. So happily though, we have moved on a bit from the genomic approach, so that even before I talk about mitochondria, we have got 4 other possible alternative hypotheses. One is the gut involvement. Lots of studies coming through now which show gut dysbiosis in autism, which, by the way, vindicates Andrew Wakefield. Serotonin dysregulation, similarly. Environmental toxins, I've just mentioned those, and I'm not going to talk any more about them today, important that they are, because they need an entire day to themselves. And then there's immune function, which I am going to talk about briefly. So, studies have shown that in the brain and cerebrospinal fluid of autistic patients, there is evidence of both inflammation and immune dysregulation. And in the mothers of children with autism spectrum disorders, they are significantly more likely to have an autoimmune disease than mothers of healthy children. Pregnant women who had an infection, an inflammatory response, or an activated immune system through vaccination had a higher risk of having an autistic child. Maternal cytokines can cross the placenta and enter the immature fetal brain because the blood-brain barrier is not yet in place in the fetus. And about transport of toxins across the blood-brain barrier, same thing. Pregnant women can also have circulating brain-reactive autoantibodies. So these may not affect the mother, but again, they can access the fetal brain. And in animals, these have been shown to permanently alter brain anatomy and cause persistent behavioral or cognitive dysfunction. And the suspect cytokine, or culprit cytokine, I should probably call it, is interleukin 17A. So this is seen in maternal autoimmune disease, and it's also been found in the fetal brain of children with autism. Around 50% of children with ASDs have higher levels of IL-17A than healthy children, and the levels correlate with autism severity. There is obviously mitochondrial involvement in ASDs. Up to 80% of children with autism spectrum disorders demonstrate evidence of mitochondrial dysfunction. The vast majority of studies show decreased electron transport chain activity, but some show increased activity. The important thing is it's not normal. It's overactive or it's underactive, but it's not normal. And MRI studies have confirmed this brain mitochondrial dysfunction, particularly abnormal energy production with elevated lactate. Elevated lactate in the brain, that's not going to go around well. And there is also abnormal intracellular calcium signaling, of course. So there is a huge correspondence between ASDs and mitochondrial diseases. I'm not going to go into that now, but you can see some of the studies showing the correspondence here. Now I'm going to talk about fever, because interestingly, in autistic children, fever can generate improvements in cognition, in behavior, in communication. And for a long time, nobody knew why. But now, studies are attributing it to elevation of IL-17A during fever-induced inflammation. And release of IL-17A suppresses the region of the brain's cortex that's linked to social behavioral deficits, at least in mice. And an injection of IL-17A had a beneficial effect on autism behavior. So that's quite interesting. But you'll probably have noticed there's a paradox here, because I've just said that IL-17A causes fetal developmental disorder with maternal immune activation. But here, in children with autism, it seems that IL-17A can repair the damage. So what's going on? Well, nobody has attempted to explain this, And in fact, there are a few people that have even noticed the paradox. But I expect that we'll be having more studies on this fairly soon. Let's have a look at our mitochondrial therapies. So ketogenic diet, yes, good. Exercise also. Can't honestly recommend anything else. Mitochondrial remedies, just these. But note sulforaphane there, because sulforaphane has been found to lower IL-17A, so that's probably how that works. And I just want to mention also that there is concern that mothers taking folic acid to prevent neural tube defects. This is going to give rise to unmetabolized folic acid, which is in fact a risk factor for autism. So you prevent one and cause the other. But I know that you would never give folic acid. You give all these better forms. I've got top 6 remedies for you here. Sulforaphane in there, of course. So while I'm talking about autism and the mitochondria, I'm going to mention the cell danger response. So this has been coined by Professor Robert Naviaux in the States. But before I say anything more about this, I want to point out that this is not recognized by conventional medicine. Some of us have tended to adopt this because we like it as a concept. But if you try mentioning this to a conventional doctor, they'll think you're even more crazy than they do already. I did a PubMed search on cell danger response, got 9 hits. 8 of them were by Naviaux's team, and the 9th was just a throwaway mention in a discussion of a paper. So neither conventional medicine nor academic medicine has any idea what this is. Nevertheless, it has great potential, as I'm going to explain. So Robert Naviaux wrote this groundbreaking paper in 2014, and he wrote a few more papers after that, and I'm going to attempt to summarize them. So initiation of the CDR, right. So mitochondria sense and respond to changes in the cellular environment. I don't think there's anything controversial about that. So when the cell detects, when the mitochondria detects a threat, which in this case is a pathogen or a toxin, the cell danger response is initiated. And what this is the release of ATP into the circulation, where it's known as extracellular ATP, for purinergic signaling. So this acts as a damage-associated molecular pattern and triggers an innate and adaptive immune responses. Cellular ATP usage is, of course, inhibited because a lot of the ATP is now outside the cell. So the normal functions of the cell are not happening or not happening so much. So how does this manifest? Well, when the cell danger response is triggered, we display our sickness behavior, which sounds a bit like autism in itself, really. Withdrawal from social contact, decreased speech, hypersensitivity, and so on. And in fact, Naviaux describes children with autism as being in a state of primed hypersensitivity, which I think is quite a good description, really. Now, normally, he says, when the threat, the microbe or the toxin, is removed, then the cell danger response will resolve itself. And it's when it doesn't that you've got a problem. So he believes that sometimes it fails to resolve, even after the inciting agent has been removed, and he likens this to cellular post-traumatic stress disorder. And he suggests that when it's stuck in the on position, this is when chronic disease can develop. And it doesn't have to be autism, it can be actually any chronic disease, and it can happen at any time in life. So he then carried out some mouse trials, in fact, 3 mouse trials. And his hypothesis was that autism results from a failure to resolve the cell danger response. The cell danger response is sustained by purinergic signaling. Therefore, antipurinergic therapy could improve autism. So let's see how that worked out. So he demonstrated the abnormal persistence of extracellular ATP caused ASD-like behavior and excitotoxicity. Great. So then he took an antipurinergic agent, which is suramin, which is an antiparasitic, and it's used for African sleeping sickness. And this demonstrated improved behavioral and metabolic features in the mice. And as I said, he did 3 of these studies. So he got the same sort of results every time. So then he felt he was ready to move on to autistic boys. So this was only a small trial, it's true, but he gave them one infusion of low-dose suramin or saline. So suramin improved all the core symptoms of autism spectrum disorders with just that one dose. 2 children who were previously nonverbal spoke their first sentence. All of the children who received suramin experienced catch-up development, and 1 child advanced through 3 years of schoolwork in 3 weeks. So it's all in here, it's just not accessible. But heartbreakingly, the peak benefit occurred after 3 weeks, and then the children all regressed back to baseline. So can you imagine the devastation of the parents? They've lost their child twice. But the trial gives hope. Has there been any independent corroboration of this? Well, no, not really. Although there is a 2015 review which looks at purinergic signaling in psychiatric disorders, and that does confirm that extracellular ATP acts as a neurotransmitter and that purinergic signaling can explain its impact on neuronal activity. So it's sort of getting there, but not really, not quite yet. But the good news is that Naviaux is running another study, SAT2 trial. It was supposed to start in spring 2021. I don't know if it did. And he's also writing a book. He's calling it the second book of medicine. So he's calling it that because the first book of medicine, he reckons, is what you doctors learn in medical school. So everything for acute conditions, absolutely fine. Everything for chronic disease, absolute rubbish. So he's taking a new approach to chronic disease by looking at it from the perspective of the cell danger response. So it'll be very interesting to see when this is actually published. No idea when that's going to be. And interestingly, IL-17A can be lowered by suramin. So maybe that's the mechanism of action. So that's it from me. Thank you. No practitioner questions, please.
I've got one question, which is a quick, simple one, which I'm sure Sarah will jump at.
Good.
If you kill microbes with vitamin C, do they not release their environmental toxins?
They might as a one-off.
Hold on.
If you kill microbes in the upper gut with vitamin C, well, it's going to be a very temporary effect. And we call that a Herxheimer reaction. My clinical experience is that's unusual.
Thank you. Damien.
This isn't exactly a practitioner question, but I love Naviaux. I'm fascinated by his stuff, and I think he's a genius, and this is clearly a great step forward in our thinking. But it's all right for you as a researcher to say, oh, well, we can just switch off the cell danger response and see if it helps the symptoms. But it really worries me as a doctor. You know, there's things there for a blinking reason, isn't it?
I know, and I completely agree. But I had a whole slide on my concerns about this, and in the end, I removed it because I didn't want to dampen people's enthusiasm for this. But I completely agree with you that Naviaux's approach assumes that the inciting agent has been removed. But I mean, as we all know from our work with patients, well, your work with patients, my work with research, there's never just one inciting agent. There are infections, there are co-infections, there are other infections, there are toxins. You've probably got at least 8 of them in your body. You'd be very lucky if you got fewer than that. And you might succeed in removing one, but what about the rest? So as Damien says, the cell danger response is there for a reason, and we need to be very careful about overriding it. And I wonder if that's why these children regressed after 3 weeks, because the body said, no, hang on, we're not ready yet. We need to do more toxin and microbe removal. And it's interesting that Naviaux didn't test for toxins and microbes in these children, and nor did he carry out any detoxification or antimicrobial protocols. He just went straight in with the suramin. Now, I don't blame him for that. It's great. But I totally share your concern there. Totally.
Rachel, yeah.
There's a kind of a profound point here, isn't there? Really, I think the same thing happens with medications. You put people on antihypertensives and the body adapts to them. After a while, it says, no, hang on, I'm raising the blood pressure for a reason here.
Yeah.
Stop stopping me.
Yeah. And what's more, I now need more of the antihypertensive.
Yeah.
No, completely agree. Yeah.
A very, very quick one, just for the benefit of everybody. I've been asked several times, what's your website address?
Oh, sorry, it was on one of the slides. Let me
It's
go back.
www.hert.org.uk.
Yeah.
See, I followed her slides. Wendy.
Can I just say a few words about my website? I've set this up only very, very recently. In fact, it went live yesterday. And you can't get more recent than that. So the principal objective is to give you additional information on the mitochondria, but it's completely free access. Nobody is tracking who you are, what you're looking at. And oh, by the way, what's your mobile number? And have you been vaccinated? No, nobody's doing that.
You don't sign in. It's just.
Yeah, it's
just
completely free, downloadable for everybody. And I've also got a few things on there on environmental toxins, lectures I've given in the past, and also a couple of things on COVID, including one letter which actually Damien and I wrote together on vitamin D dosage. So there you go, to Matt Hancock. So. Yeah, so feel free, download whatever you want. It's all there. It's for you. Really, it's for
Wendy.
you.
Just in your travels or in your studies in preparing for this course, did you come across a study showing that statins could actually be useful for Parkinson's disease, prevention for Parkinson's disease? And if so, do you have any thoughts about that research, please?
Could you ask that question later when Gillian
To
is
Lucille.
talking? Because
Happy to.
because I deliberately didn't research Parkinson's because Lucille and Gillian said they would do that. So
I wondered.
yeah, but do ask it again because it's a very good question. And maybe it's like nicotine, also beneficial in Parkinson's. Very odd, but true.
I'd just like to mention the research of osteopath Isabella Bramari Castellao, a Brazilian who basically did visceral osteopathic techniques on 49 children and noticed improvements in both subjective and objective criteria. In other words, working on the gut made a big difference to them. Her thesis was that they're suffering from sensory overload, and a massive amount of the overload, the background overload, comes from gut dysfunction.
Great, thank you.
Okay, thank you, everyone. I think this is a good point. This is Rachel's last lecture, just to say really big thank you to Rachel. The amount of information she's collated for today is absolutely spectacular. I know you can't help but learn a lot from every single slide she puts up. So, and I'd like to thank Rachel as well for all the help she's given in putting together today. So thank you.